Hi, I'm Dr. Jeff Clement. Welcome to this week's module for PA 708, the Business of Healthcare. This week we're going to be talking about healthcare payment systems and reimbursement models. And while insurance is not everybody's favorite topic, it certainly impacts the way that care is delivered and shapes even our own lives. So hopefully you'll gain some useful knowledge that empowers you to both operate within your organization and take better care of your patients. And the crux of what we're going to talk about this week is this question: who actually pays for the care that you deliver as a PA, and why does that matter? Why does it matter who's paying for it and how? I mean, I think intuitively we all know that it does matter, but understanding some of the nuances can shape the way that you do your job, potentially the way that you choose to run your organization as you advance in leadership roles, and help identify ways to align incentives like we've talked about in some of the other modules so that you can make things better for everyone. In the first part of this lecture, we're going to talk about how healthcare gets paid for. There's a number of sort of big key ways, and any one of these topics we could spend an entire semester on. There are reams and reams of health economics literature. There's multiple textbooks on each of these different systems. Each one of these topics, I'm covering at a very high level, and there's a ton of nuance, differences between plans. It's all regulated at the state level, so there's differences between how things play out in different states. So, I'm going to sort of be hitting very much the wave tops. You take that for what it's worth. As we look at a breakdown, this is from 2023, which is the most recent solid data I could find, but it hasn't changed much over the last few years, really. So employer-provided private health insurance is the single largest category, coming in around 48.6% of the population. Numbers I saw were like 150 to 160 million, 157 million people in the country have some kind of private insurance. So that's the biggest category for sure. Coming in second is Medicaid. So Medicaid is sort of it's a very tricky program. Again, varies substantially state to state because it's administered at the state level with federal subsidies. So the state implements a Medicaid plan, and then they become eligible for those federal subsidies. And so there's a lot of variation state to state. Primarily aimed at people who are lower income and don't have other access to health care. We saw a big expansion of Medicaid, so states were given the option to expand eligibility limits, income eligibility limits for Medicaid under the Affordable Care Act, and we saw sort of that slow rollout across a number of states, and even in traditionally red or Republican states, many of them have chosen to expand Medicaid. So it is a very popular program in making healthcare accessible to people. The next group is Medicare, which is primarily, and we'll talk about all these in some more detail, although, again, each of these buckets are very nuanced, lots of subcategories. Generally, your retirees, although there's also a couple of other categories, including anybody with end-stage renal disease, which is, again, used to work in transplant. When dialysis first became available, it was prohibitively expensive. There was no way anybody could afford it. And so they wrote it into law that, hey, if you have end-stage renal disease and you need access to this life-saving treatment, the only one that was available at the time, because transplant didn't exist for kidneys yet, they said, you qualify for Medicare as soon as you're diagnosed with end-stage renal disease so that they could pay for dialysis. So, again, there's all these like little quirks. Well, this plan covers these folks. And also these other small categories, right? And then non-group, that's going to be some other type of insurance plan or scheme, group coverage. And then, we've got uninsured folks. So that's about 8% of the population still. The Affordable Care Act did reduce that by several million people. Not just several million, millions of people gained coverage under the Affordable Care Act. So big progress there, but obviously we're not all the way there, and there's still further to go. And then last is the military at 1.3% of the population. Now, that also includes military dependents and families, as well as reservists. So there's access to some really good health care if you're a military reservist. So there's a good chunk of the population that take advantage of that. That does I should have checked off the top of my head. I do not think that this includes the VA. I'm guessing that is in non-group, but the VA is probably around 0.5% or so of the population. The military is a very interesting population when it comes to health insurance. We'll talk about them a little bit more in this lecture because they're a population that you have really, really good data on, and you can sort of observe what happens over time. And so there's a good amount of research in the healthcare space beyond things that one might traditionally associate with the military. And again, since it includes all of their dependents as well, it's not just like, oh, it's a bunch of 18-year-old guys. It's like, no, it's like, people across the age, gender, and sort of life stage, life spectrums of life, who are lumped in there. So that it's an interesting population to cover. All right, so public payers, we can talk about them in more detail. They're going to cover the most vulnerable populations, and this also sort of has the effect of setting a price floor. So Medicare is, as we mentioned, covers mostly retirees, adults 65 and older, also some certain disabilities, and end-stage renal disease, like we talked about. So there's about 67 million folks on there, pays via RVUs. We're going to hit that in more detail in the next module, module 6. That's a long one, so this week will be a little bit shorter. This serves to sort of anchor prices for negotiations for all of the other types of plans. There's 4 main parts of Medicare. So Part A covers hospital stays. Part B will cover anything outpatient. Part C is Medicare Advantage. We'll talk about that. And then Part D is the supplemental drug coverage. So sort of splits out. I mean, I remember, I guess I'm a little bit old, but I remember I was, probably 10 or 11 when Medicare Part D finally went into effect. It was a big deal. And a lot of people really, really appreciated that expansion. Traditional Medicare, there's a couple different flavors here, but traditional Medicare is fee-for-service by default. We're going to talk about different reimbursement models. So this is, you get a service, you pay for that. So you go, patient goes and they see their, let's say they go see their primary care provider, and they get seen for, management of some disease, and the provider gets paid X amount of dollars based on the RVUs for that service. Medicaid, again, federal-state partnership. We talked about that. About 90 million beneficiaries. Again, the rates are set by the states. It's going to be a substantial discount off of the Medicare reimbursement rate, typically. Again, all these lots of quirks, but by and large, the Medicaid reimbursement is going to be the lowest reimbursement for that provider, and this introduces a number of issues. And then CHIP and VA, these are smaller public programs. The VA operates its own integrated delivery network. So, for example, here in the Twin Cities, there's the VA hospital down by the airport. Or on your way to the airport, down by Minnehaha Falls, that area. Coincidentally, that's where I get all my healthcare. I've had a great experience with the VA. I've also, before I came to Minnesota, and was working in the pharmaceutical industry, knew a number of physicians working at different on the transplant side in the VA system. Some of the most fantastic folks that I have worked with. So again, another sort of interesting sort of special population in terms of providing care. So the commercial plans and employer-sponsored plans that we're all very familiar with in the United States became dominant here almost by accident. So after World War II, you had all the soldiers returning, you had the GI Bill, you had all of the industrial investment that had been made as part of the war effort, really just pumped up the economy. And there was this economic boom, there was a baby boom, and then there was also, though, inflation associated with that, with wages getting higher and higher and higher. And so the government put some wage controls in place to try and control that. Well, what was the impact of that to you? Let's say as an employer, you want to hire workers to come work for your company. You're literally not allowed to pay them anymore what do to get them to come work for you instead of your competitor down the street? You lobby the government and get an exception carved out for benefits, including the new health insurance that is sort of, on the rise. And so you were allowed to offer health insurance as a nice benefit to your employees. And at the time, it was sort of meant like a perk, like, kind of like a gym benefit or something might be today. But over time, it became enshrined as a, part of the core compensation for employment here in the United States. And in 1954, there was a tax exclusion that made the premiums tax-free, which made it even that much more attractive, right? These plans, again, they're the dominant form of health coverage here in the United States. And the rates are going to be negotiated with the payers, generally between 130 to 200% of the Medicare rate. But again, so Medicare is serving as the anchor. Some companies are self-insured. I think we've talked about that where, you have a card that says Blue Cross Blue Shield, but your company is basically just that. It's almost like a debit card. And so you're swiping it, your company gets the bill. Blue Cross Blue Shield, Health Partners, United Healthcare, they're just administering those transactions. And then last in the commercial space are the individual and marketplace plans under the Affordable Care Act. So these plans, they have to cover 10 essential health benefits. So a lot of the primary care stuff, preventative care. There are some exceptions for short-term plans, which are sort of meant to cover, say, like gaps in employment, things like that. I actually purchased one at one point. I wanted to take the summer off before I started my PhD, move out to Minnesota. So I quit my job and, was like, how do I make sure I have health insurance, in particular for my child? So I bought one of these short-term health insurance plans. They're cheap, which is attractive, but they basically only cover catastrophic stuff. Here's my one rant about the Affordable Care Act. People don't appreciate it for how much it does, and they do not remember at this point what it was like in the days before the Affordable Care Act, when insurance companies could discriminate based on things like pre-existing conditions. So I don't think I need to convince any of you all to lobby your lawmakers to ensure that your patients retain the benefits under the Affordable Care Act. But tell your patients, to make sure that when you hear them point something out, be like, hey, you know what? Like, that's a result of the Affordable Care Act. Tell your lawmaker. Be sure to vote, right? One of the things to keep in mind about these plans, there's a lot of frustration that, the Affordable Care Act isn't working as intended. It feels like, we were supposed to have more plans. There was supposed to be more competition and more availability. Yeah, absolutely. A few things happened. One, they got rid of the individual mandate, which was, this class, we talk a lot about incentives. The individual mandate was critical to ensuring that people actually enroll in the plan and that you have people in the marketplace. This was part of the original design of the plan. It was in part of the sort of the pilot program that, or the model that was used in Massachusetts, which was developed by Republicans, by the way, and implemented under Governor Mitt Romney at the time. So then they got rid of that. What is one of the big results? The result is that the risk pool is thinner than for employer-sponsored plans. What does that mean? It means that people who are sick or have chronic conditions and know that they need healthcare are going to make sure that they buy insurance. People who are a little more, they don't have a chronic condition, they aren't quite as sick, they're younger, they're healthier, they're just going to be like, I'll take my chances, right? And so this results in, a more expensive coverage, or insurance companies just choosing to exit the market entirely rather than provide coverage for those folks. The other sort of, factor at play here is that people who, again, we're talking in averages, all this stuff in insurance and coverage, it's all about the average, right? Because fortunately, you can't really discriminate on an individual level. With a few exceptions for things like, I think, smoking and stuff like that. But, the insurance companies can't discriminate on an individual level, so they're going to look at the average. And on average, people who are younger and healthier and higher socioeconomic status and better education tend to be working at better jobs that are better compensated, that have better health benefits. And that means that they are on an employer-sponsored plan. And that's where they get their health insurance. And, other folks are sort of, left on their own, and they're on the individual marketplace. And so you have a much sort of sicker population on average, and that's why some of those plans are less available or more expensive. So, what is the effect of tying health insurance to jobs? It's not great. Okay, so there's a really interesting paper. This was published in 2019. It was 2019. That looked at the impact of the Affordable Care Act on basically were people likely or less likely to quit their job, or are people less likely to quit their job if they rely on their job to provide health insurance, right? And so these two economists use the Army as a sort of test case here. So the military has, it depends who you ask. Overall, like I would say, experiences are mixed, but the military covers healthcare for all of their active duty service members and their dependents. Okay, and when the Affordable Care Act comes out, right? So if you're thinking about leaving the Army, you're like, oh, you know what? Like, we all complain about military healthcare, but you know what? It is healthcare and it's there if I need it. And if I quit, I'm going to have to figure something else out. In particular, if I go to college and I'm not working full time, where am I going to get healthcare? And so they exploit the rollout of the Affordable Care Act and find that the Affordable Care Act decreased re-enlistment rates by 3.13% for enlisted soldiers. Okay, so this means that soldiers were more likely to leave the Army after the Affordable Care Act made the individual and marketplace plans more of an option. And in particular, it made those folks more likely to go to college. Okay, so I think these are all good things, right? We, in general, obviously, we all respond to incentives, but the disproportionate incentive that is the result of health insurance being tied to your job is overall probably a negative thing for individuals and our society and our economy, if you think about like from a capitalism standpoint. And there's sort of, in this paper, the authors make three big arguments for why this, what we call job lock, is a bad thing. Okay, so first, it discourages individuals from entrepreneurial ventures in particular, right? And so, even if you're like, oh, I could quit this job and go get another job, sure, right? But like, what if you have a good idea for a small business? And small businesses are a huge part of our economy. It's a political talking point, but it really is true. Small businesses are really important to the economy, and sort of responding to the needs of the marketplace, all this stuff. If you have this great idea, but don't have the option of getting health insurance anywhere else, you're going to stay with your big company, big corporate job, right? Second, it encourages employees to stay at a job, even if there's a better job out there. Okay. So, if the job you're at has like decent coverage and there's a better job out there, but like, their coverage is worse, it's going to lock you down, right? Especially in like small towns, maybe where there's not too many different employers available. And then the third effect is that it can increase what's called the intensive margin. So extensive margin is like how many people work. Intensive margin is how much do you work. And so we might see that a lot of people would prefer to not work quite as much. Maybe parents with new kids, they might want to work, hey, I want to work 20 to 25 hours a week to just keep my skills sharp, get out of the house a couple days a week, make a little bit of cash. But I don't really want to be full-time right now. I want to spend that time with my child. And there's a lot of reasons to believe that, like, hey, maybe that's actually optimal, like for a lot of people. The economy in general, like that might be good for a lot of folks. But you know what? I have to work 35 hours a week to be eligible for healthcare at this company, so that's what I'm gonna do. And that's maybe suboptimal. And so the effect of job lock is generally, and this paper focuses on the Army, but there's lots of other examples that show this effect of job lock. The Army is again a nice example for a lot of these things because it's a really clean, homogeneous setting, and you have a lot of control and a lot of really good data at the individual level. Like they have individual data on every single soldier who enters or leaves the Army, and it's a huge organization. You don't have many organizations this size where you can get this level of data. Okay, so the next few slides, we're going to do like a lightning round. So we talked about where insurance comes from. We're going to talk about, within some of these different categories, like lightning rounds of different ways of organizing that care. Okay. So first, HMOs, health maintenance organizations. These have really sort of fallen out of favor in a lot of ways, and maybe the term isn't quite as used. Very big in like the 90s and then into the early 2000s, but they're still around. Okay, so an HMO is a managed care plan where you receive all these covered services through a designated network of providers. You pick your primary care provider and they are the gatekeeper. Okay, you want to see a specialist, get a referral for anything. The idea here is that you're going to lower premiums because we're going to really lock down the care. We're going to provide it through a consolidated network, and we're really going to, ratchet down the utilization. I think we'll hit this. There was like this term like drive-through deliveries, like you're going to be forced out the door. You have very little choice. They're still around, in a lot of ways. Kaiser Permanente out west, and a lot of the Medicaid managed care plans are HMOs. And we'll talk about pros and cons. A PPO, a lot of us, may get our care through a PPO. So this shares some of the characteristics with an HMO in that you have this network of preferred providers, but you don't have that same level of control. And so it sort of incentivizes the patient, like, hey, why don't you stay within network with these folks that we've negotiated? You don't have to, but you're going to pay higher copays, higher out-of-pockets if you go out of network. Okay, so then you got the lower cost in network, higher out of network, slightly higher premiums because you don't have that that provider or the primary care provider as the gatekeeper. And again, pros and cons there. Like if you know that you need to see, I know I need to see an ear, nose, and throat person. Like I've got something going on. Well, then maybe it's faster for me just to make the appointment with the ENT. On the other hand, now maybe the specialists are all overwhelmed. Okay. This is, however, the dominant type of plan these days in employer-sponsored health insurance. The last couple places I've worked have all had a PPO plan as an option. And again, less utilization management, meaning less control than the HMO, but still trying to keep people in a network. A point of service plan. So this is sort of a hybrid. So you have a primary care provider who coordinates the care within the network, but then you can also leave the network. So you sort of have this 3-tiered cost structure for stuff in network through your primary care. Then you've got the in-network specialist and then out of network. These are it's like a blend. I think some of the Medicare plans function this way. I haven't ever personally experienced it, so I can't speak too much to these. ACOs are not strictly a plan, okay? So it's not like an insurance plan, but it's a payment and delivery model. Basically, it represents a network of doctors, hospitals, and other providers who are going to try and coordinate care for this defined patient population. They're going to try and meet certain criteria, and if they do, then they'll share in the savings, okay? So the idea here is you coordinate care, reduce fragmentation, improve population health, and get away from some of the just like bill and compete with each other, that kind of thing. All right, but ultimately, where this comes in, especially as you enter, say, like a leadership role as a PA, you're gonna really pay attention to like the split of where your patient's care is being paid for. Okay, so Medicare, they're sort of setting the rates based on the RVUs. We'll talk about that in a lot of detail in week 6. And this becomes then the anchor. Medicaid, they're going to pay much lower rates. This is why you're going to see your critical access hospitals in particular are going to really struggle financially because Medicaid patients, again, on average, are paying, their coverage is reimbursing their care at a much lower rate than it would for another patient. So let's say a Medicaid patient is paying 60% of what a Medicare patient would. So Medicare sets the rate for a particular service, let's say for $100. Okay, so the hospital will get $100 for whatever it is. The Medicaid patient, they're getting $60. Okay, that's a, where's that $40 coming from? If Medicare is paying $100, that service costs a lot more than $60. So you're losing money on all of your Medicaid patients, quite frankly. And what happens then? Well, the commercial patients are subsidizing that, right? So if Medicare is paying $100, then the commercially insured patient is going to pay $200, right? And so this is where like the system, it all has to balance at the end. And this is where you have this spread between these rates is the financial reality of any practice. And this is where a lot of the, you see the editorials and the news articles that come up that, like, oh, this practice won't accept any more Medicaid patients. Like, yeah, like that's the reality, and that's a practice management decision that practices have to make. I've also sort of seen it the other way. I had a friend, they were traveling, and they happened to be a physician. They were traveling to visit a friend, and their daughter got she got a small bead. She shoved it in her ear, and happened to, her friend had an otoscope and at home. They're like, yeah, that's way in there. We'd really the ENT example. We'd really want to have an ENT deal with it. It is way in there, and even as a primary care physician, I don't feel like I should be doing this at home. So they call sort of friend of a friend of a friend, and they're like, is there any way you could come see us today? And we're, traveling, we're in the middle of, we're kind of in the middle of nowhere, this ENT practice, and like, we are completely booked, but let me talk to the practice manager. And so the practice manager calls and is like, you're commercially insured, right? And my friend is like, oh yeah, I got my insurance. And they're like, absolutely. What? Come whenever you want today. We'll fit you in. And so it's like, it's sort of, we'll talk about health equity issues, but so on the one hand, it's like, that's really not fair, because I bet if it was a Medicaid patient, they would have been like, no, we're all booked up today. On the other hand, they're able to see all the Medicaid patients, because getting one more commercially insured patient through the door today will subsidize a few of the Medicaid patients. I don't have a great answer for this. How do we handle this? I don't really know. I don't have a great solution for it. So we're leaving off this first part of the module in a little bit of a downer. Again, I don't have a great answer to a lot of this, but these are the realities that you have to balance when you're, doing the practice management role for your organization. In the next part of the module, we're going to be talking about how these different payment systems try to bring in the idea of value of care, and moving just beyond, raw dollars to actually health value. And then in the third part of the module, we'll begin to talk about some of the policy trade-offs. So I hope this first part has been helpful, and I'll see you in the next one.